Thank you very much for inviting me. It's a very exciting meeting. I think also a very important meeting. Get patients and doctors together. This is a case for debate. I have to get the next slide. So what we present today is a woman, 42 years old, and in fact in 2016 she presented with her rheumatologist, and it appeared she had high blood counts, and she was diagnosed polycythemia vera with JAK2 positivity. Her bone marrow biopsy fitted with that. What we learned this morning is that megakaryocytes is the cell line that's abnormal in the bone marrow, the most abnormal. And that's what you see here, megakaryocytes which look abnormal for the pathologist. And important to know, and that's why I always do a bone marrow biopsy at presentation, is that there is no fibrosis. So she received phlebotomy, and then she started to feel more tired, sick, and dizzy. So the question is, should we go on with phlebotomies or choose for another therapy? So, first of all, I put up some treatment goals. Why should you treat a patient with a polycythemia vera? First thing is, of course, to reduce the risk of thrombosis. And we know that in the risk of thrombosis, both the hematocrit, so the number of red blood cells, the relative number of red blood cells, and leukocytosis are important, more important than thrombocytosis. Of course, it might be nice if we can reduce the risk of progression to myelofibrosis or leukemic transformation. We also have sometimes bleeding risk, which are often ignored. But I have several patients with bleeding risk, especially if you operate them due to a fulvilant factor shortage. Then a treatment goal could be, since this patient is feeling tired, it could be that she develops constitutional symptoms, which you find most of all in myelofibrosis, but also ET and PV patients can have much complaints, constitutional symptoms, tiredness, they can do their work, and maybe an effect on the disease itself, the allelic burden, which was discussed this morning. So we have to, my idea is that we can perhaps better control the disease with a cytoreductive agent. The choice is whether it's interferon or hydroxyurea. The question is there a role for ruxolitinib? And I put up ferritin and iron levels. Sometimes if you do a lot of phlebotomies, patients get very low in their iron, and that may affect. Iron is also needed for other enzymes than just the red blood cell production, and so that might be a factor. And of course we have to give attention to additional risk factors for thrombosis, like smoking, hypertension and diabetes. Why? Well, this slide shows in the left upper part the reason this patient is a candidate for primary prophylaxis. She didn't have a thrombosis. And so the guideline says you should give her phlebotomies, only hydroxyurea if she is more than 60 years old, which she isn't, and give her a low-dose aspirin, which she has. Why I suggest to give her treatment? This is an analysis done from a randomized study in which they compared hydroxyurea with phlebotomies. And what you can see in this slide is that the outcome this is a selection within this study, so we have to be very careful in interpreting this. But what you see is that I have a red defect, so I don't see these. Well, what you can see is that the patients which are treated with hydroxyurea have a lower risk of accidents, cerebrovascular accidents, and also a suggestion that they have a lower risk of transformation. So that would be an argument for me to treat patients, and also the overall death is somewhat lower in this group. And this is illustrated here. You see on the left side the patients with a good control of hematocrit. That's better in the patients treated with hydroxyurea. There is a better control of white blood cell counts, which I told you is a risk factor for thrombosis. And there is also a somewhat, well, that's not much of a difference, but the platelet counts are more or less equal. But I told you platelet counts are not the most important factor in the risk for thrombosis. So my argument is I treat this patient, I advise to treat this patient because he has less fatal, non-fatal CVAs, myelofibrosis transformation was only seen in the phlebotomy group, and evolution to acute leukemia was seen in 3 patients, and that was also higher in the phlebotomy group. Just another slide on ruxolitinib. And what this slide shows is that if you look at the control of the disease measured by allelic burden, that perhaps ruxolitinib is adding somewhat to interferon alone. So that would be an argument to give ruxolitinib as a disease control. Like Claire told this morning, ruxolitinib is very much capable of controlling blood counts. The problem perhaps is that we have no idea about long-term effects. And if you treat a patient with PV, you might treat him for 20 years or so. Okay, that's my part of the story.
So if I was to sum up, Reinier, you believe that treatment is a good idea for this patient primarily because you believe it will reduce the risk of thrombosis and reduce the risk of transformation. Would that be the 2 main points?
And a better control of disease.
Fantastic. Okay, very good. Thank you very much. Now let's hear the case against.
Okay, thank you. So we have a 42-year-old who is at low risk. She has had no thrombotic events. And do we wish to treat her or not? Well, the first bit I would contest is this is the most up-to-date algorithm from Professor Teferi, who changes his algorithms every year. But even Professor Teferi defines low risk, and we now have very low risk disease, and our patient falls, and you can't read this, Lisa.
You're going to have to talk us through this, Mary Frances.
And I'm going to have to go up and look at it to talk you through it. So low risk disease is less than 60, no thrombotic events, and JAK2 positive. And sorry, it hasn't projected, but basically the advice is low dose aspirin and venesection. You only would consider higher doses when you get to intermediate and high-risk disease, where you then bring in the cytotoxics. So, basic point, why would you want to treat somebody who is clearly of low risk by any staging system that you want? Other things, what are you going to treat them with? Well, the first thing you are going to do is venesection or phlebotomy, and this is the CytoPV study, which is really the trial in this, which looks at randomization of patients between a hematocrit of less than 0.45 and higher than 0.45. And you can see what you want to look at is with the low hematocrit, the lines are almost at baseline, that the number of events are very, very small. So with a patient with a well-controlled hematocrit, the chances of events long-term are very small. The other treatment you would want to consider in this patient is low-dose aspirin. And again, this has been tested in a randomized study in the ECLAP study in patients in PV. And again, the patients on aspirin, low-dose aspirin versus placebo, you can see that the event-free survival is much better in the aspirin-treated group. So we have good information that in a low-risk patient, you get good outcomes with phlebotomy and aspirin alone. What about cytoreductive therapy? Well, I think we have to think very carefully if we want to do this in this patient. There are events that we need to think about which have implications for the patient. Hydroxycarbamide. So we give this 42-year-old woman hydroxycarbamide. Now, we've argued about hydroxycarbamide for many, many years, about the leukemogenic effect. Some people, the other side of the big pond, believe in that greatly, but it's never been proven. But there's certainly incidents that there are increased skin cancers on patients in hydroxycarbamide. And I would certainly warn any of my nice, fair-skinned Irish patients to stay out of the sun if they're on hydroxycarbamide.
Sorry to interrupt, Mary Frances. Just for the rest of the audience, hydroxycarbamide and hydroxyurea,
are the same
thing.
It was the European Licensing Authority said we had to call it hydroxycarbamide. So there is certainly a risk of skin cancers and second malignancy. Interferons, great drugs if they work, but they also have their problems. There are really quite high dropouts in all the interferon studies with psychiatric disorders and other side effects. So, and I could also add in ruxolitinib, which is licensed for patients who are hydroxycarbamide resistant or intolerant. So they have to have that first if they were to go down that route. But it also, we really don't know what the long-term effects, and it certainly has some effects on the immune system in patients in ruxolitinib. And we've seen patients, albeit rare patients, with very severe infections on ruxolitinib. So once you introduce cytoreductive therapy, you bring out the possibility of doing harm. And I did Latin at school, and in medical school, and primum non nocere is the first thing we are told as doctors: first, do no harm. And I think you have to consider that in treating this low-risk patient. The final bit, I would say, and this is a slide very kindly given to me by Professor Harrison, this patient has symptoms. She's tired. But I think you have to look at this in the bigger picture and look at the ways that you could manage this. Remember, depression is a common cause of fatigue. There are a number of different ways of managing the fatigue, and also fatigue is a side effect of some of the drugs as well. The itch, which is also often an issue, there are many other non-cytoreductive ways to think about in managing the itch. So I would, in summary, contend that this is a 42-year-old low-risk patient, that her best chances long-term of avoiding events are purely on venesection and aspirin. And of course, she needs to look at have her other problems looked at and see if they can be managed in some other way. Thank you.
Thank you, Mary Frances. So before we go any further, let's just have a show of hands from the audience right now. Who thinks that Reinier is right to treat this patient with hydroxyurea? Hands up. Okay. It was 3 to 4, I think, a year, wasn't it? Okay, now hands up who thinks better off on low-dose aspirin and 3 to 4 phlebotomies a year. So, okay, so it looks like Mary Frances's approach is slightly more popular at this point, but we do have significant support for the treatment option. Okay, so now I'm going to throw in my kind of provocation into the argument. So I'm now think of me as a 42-year-old woman. Everybody got that picture in their heads? Okay. So now I'm in the office, I'm in the doctor's office, and I'm thinking to myself, so you said there's a risk of me having a blood clot, right? So that's pretty scary. I've heard of people who get blood clots. They have strokes, right? They have heart attacks. They die of those things, right? So I'm pretty scared about any risk of having a heart attack or a stroke. So I think on balance, I might probably prefer to have something that's going to reduce that risk. What do you say, doctor?
Okay, well, first of all, in life, there are no certainties. There is no zero risk.
I don't want to hear that.
I don't care whether you want to hear it or not. That's actually the facts. But if you look at the evidence with low-dose aspirin and venesection to less than 0.45, you actually get that risk down very low. I don't fully believe the evidence taking a subgroup from Professor Barboui's study and looking at that on its own proves the case otherwise, that you're going to get it much lower with hydroxycarbamate. This is a low-risk patient.
Rainier's told us it's a great drug.
Well,
He didn't tell us anything about it.
in response to that, what I showed is that at least patients with only phlebotomy, and there are more data in the literature, often have a too high hematocrit, and there is a New England paper publication that shows that you need to strictly reduce the hematocrit below 45, at least in men, perhaps lower in women. There are no good data on that. And that's better reached if you use cytoreduction, that's what I showed in my slide, than a phlebotomy alone.
So, doctor, my husband has had a second opinion. And Dr. Raymakers told us about this wonderful drug that he could take, and there's lots of good side effects. You know, the side effects are minimal, and it's got lots of good efficacy. Do we have a choice? Could we not request to be able to take this new innovative drug?
Well, I think within the license, which is where the trials were all done showing the efficacy, it was in patients who had hydroxyurea resistance or intolerant. So the efficacy is shown in that group. Now, the argument I'm making is that you don't want hydroxyurea in the first place, never mind moving to that. You may live in a country where you can give drugs without license, but that is where the trials were done and what the license is. The other thing is that although it is, I mean, I have actually used ruxolitinib and in the trials, and it is effective in some patients, it is not without its side effects. And in particular, in this situation, again, on a 42-year-old low risk, it's become a man, it's your husband now, isn't it? You know, I will be warning about the testing them for hepatitis. Is there any history of TB? Is there reactivations of TB? There are several cases of patients getting a major neurological reactivation of viruses with this, albeit very rare. But, you know, it's very good in the context in which it is used, but is this something your husband wants up front?
Well, I guess I would have to say, as you mentioned, there's nothing for sure in life. So I would say that, you know, perhaps we would be in the best position to make that choice of whether the patient wants to take it and have the risk of perhaps dealing with those side effects. So really it should be up to the patient's choice.
Well, to some extent, but you have to accept the work that has been done and the opinions. You know, I would see it as my job as a doctor not to tell you what to do, absolutely not, but to present you with, and also as an expert, make a suggestion within the treatment. I mean, I think you have to allow some expertise from the doctor as well.
So she's playing
Maybe.
the expert card now. Okay, good. John, but seriously, Dr. Raymakers, you've told us a lot about you've told me a lot about the efficacy, the great things that this drug is going to do for reducing the risk of getting a heart attack or a stroke. But you didn't mention the side effects when you were opening the argument. And the more I hear about those side effects, the more worried I get.
Of course, every drug has its side effects. Now, there is another issue that in this case report, this patient is tired. And so something changed in this patient, because before that she did well, and then I think, but now there is something changing. And of course, you may think that she is depressed, but in my experience, many patients with PV have complaints. They are tired, they can do their work because of their disease. And that's something that we doctors should be much more aware of. And of course, we would like therapies that influence also these complaints. That's difficult. Sometimes you see that interferon has effect on these constitutional symptoms, as we mentioned it. Also with ruxolitinib, you see, especially in MF, of course, a serious reduction in constitutional symptoms, which are important for quality of life. What I do in practice is sometimes try these drugs and see if symptoms are reduced, yes or no. And so that's a more practical approach. If we see that symptoms do not change, then we could decide to get you off the drug.
Okay, we're going to move on to a second case in a second, but we've now heard two arguments for and against treatment, and we did a quick show of hands at the beginning of that discussion. Let's have the same show of hands again now, see if anybody's been swayed one way or the other. So hands up for the treatment option to go with Dr. Raymakers. Okay, I'm thinking maybe one or two extras there, I'm not sure. But now, those of you who agree with the don't treat for now option. Oh, pretty close now, I think. Maybe you did manage to convince the audience slightly, Dr. Raymakers, but I don't think you're quite there yet. Okay, shall we move on to the second case study now, please? Great. Who's going to describe this one?
While they're transitioning, John, to not treat never addressed dealing with the symptoms that the patient had. So it felt like, as the 42-year-old, I was just saying, no, I'm not going to treat you, and
deal with it.
Go deal with it, which some of us have heard for quite a while.
Suck it up, yeah. Okay, fair point.
Is the answer to that the last slide? Sorry, the last slide gave a whole lot of potential dealing with the symptoms. Think about the depression, think about what you can do with the pruritus, think of all the other things you can do. That was the point.
Okay. Shall we hear about the second case study then?
So this is a woman. She is 69 years old, and she has a ET that developed into a fibrosis. She had an ET for many years, 1995, and she was treated with interferon. But in 2015, there is a change. You see that her hemoglobin goes down. Her platelets went down, and also in her white blood count, you saw a left shift. teardrop cells, so then she develops a post-ET MF. And she was treated for her anemia with EPO, RNS, but that was not effective and that was stopped. And then she further developed into myelofibrosis and she became transfusion dependent. So she is 96-year-old and what? 69? So the question is, would you offer her a transplant? Her prognosis is, well, if you look at the transplant given her prognosis, if we look first at her prognosis, she is more than 65 years old. She has constitutional symptoms. She has a low hemoglobin. She is transfusion dependent. She has, well, we are not informed about cytogenetics, but if you use this DIPS score, she has at least 4 of the arguments, and that means that she has a median survival of 16 months. And that's shown in this graph. So she is an intermediate 2 patient, at least. We are not completely informed. So, well, this also shows the survival in the 4 subgroups. What I would like to know is additional information. We heard about molecular biology this morning, about new mutations, and we know that patients with myelofibrosis during their disease development may acquire new mutations which are prognostic. On the left side you see ASXL1 and SRSF2, and these both are mutations. If this patient has these mutations, her prognosis gets even worse. So I would like to be informed about that. And transplant in myelofibrosis, it's not so easy. If you transplant too early, you'll lose a lot of years a patient might have spent in good health. If you transplant too late, you will lose a lot of patients because their disease was already so progressive that you can't cure them. So it's always very difficult to find the right time point. If you look, this is an accumulation on a time scale of all, there's an accumulation of trials, allo trials, and what you see is that we are doing somewhat better in, I can't quite read it, the 5-year overall survival. So we are making progress in transplant. We first had the intensive transplants. Now we have reduced transplants, although we went back to a mixed form of partially reduced intensivity. So we're doing better. So I think there is a real chance that this patient will benefit from a transplant. And of course, the age, this patient is 69, not 96, and we transplant until an age of 70, 71, depending on the patient's condition. If a patient is in a good condition, if she has a good functioning heart and lungs and so, there are risk scores also for these, then we still would consider an allo transplant.
Thank you, Doctor. I believe there is an argument against transplant, though.
Okay, so you can see I got the negative point of view with a lot of this. We didn't pick, we were allocated. So We want to transplant this 69-year-old with post-ET myelofibrosis. Well, I am going to say no. So the first thing we want to look at, and we quote all the time at patients, these survival scores in myelofibrosis. And in fact, we've seen one of these, except it was in primary myelofibrosis for starters. The DIPS all these scores are done in primary myelofibrosis. And of course, this is a patient, as many of the patients that I now see, because I've been in practice for many years coming through, are post-PV or post-ET. And I would contend we don't actually know an awful lot about what their long-term survival is. This study actually tries to look at this. It's the most recent, and it's a thing called a MySEC score in patients with secondary myelofibrosis. And on scoring them, it divides them up. I'm not doing very well on slides today because all the things I've taken haven't projected very well, but into the low risk, intermediate risk, and high risk, and is then looking at survival curves. Now, in survival curves, you always want to go about the 50% mark. And even in that, even in the intermediate and high risk, you're still talking about a 50% survival of out to about 4 years. So for the individual patient, what are we talking about here? How can we say, oh, you've got post-ET, post-PV or post-ET MF, your predicted survival is? It means nothing. I have seen patients with these disorders who have lived for many, many years, but I've also seen other people who had quite a short survival. So trying to predict and give somebody a score is really very difficult. You can't, no patient can be 50% of anything. The other thing which we look at is look at what happens when we transplant these patients. And I have heard people standing up on platforms, as I'm of course doing now, saying there is no patient that you can't find a donor for in transplant. There is no upper age limit. You have an upper age limit of 70 or 71. Our patient is 69. But I think you have to think about what you're doing when you do a transplant. So this is a study from North America looking at RIC, reduced intensity transplants, in patients with myelofibrosis. And if you look here, this is the overall survival line. So within about, I can't tell it's 1 or 2 years, but you've basically 40% of the patients don't survive. If you also look at this is the probability of disease-free survival. The line's right down there. So again, your 50%, that's the number of people alive at that period of time is well down. And you can also see these lines coming up are the probability of relapse, which is coming up to join that line, and the non-relapse mortality. So this is the percentage of patients over time who die but don't, without relapsing their disease. In other words, they die as an effect of the transplant or something connected with it. And I think when you're proposing a transplant, it needs to be in the context, what are you actually trying to do with it? And you again back to this all the time. Oh, we have good results. 60% of our patients do well. But our poor 69-year-old can't be 60%. She's 100%. I point this out with transplant. We do awful things with transplant. This is acute graft versus host disease. RIC patients probably get this less, but they go on and they get chronic graft versus host disease, they get recurrent infections, they get awful problems. So I think we have to think of what we're proposing for this patient to transplant them. The other thing I would point out, and this is actually from the Landmark study, is what do the patients want? And this is a study, as you know, looking at what the physicians' goals were for the patient. And physicians are great. They want to treat them. They want to cure the disease. They want to get rid of all of this. But actually, what is important to the patient are slightly different. Quality of life becomes much into this. Yes, they want to prevent the vascular events and needing anemia and things like that. But what are the priorities for the patient? And if you do a transplant, you might even get to the survival bit of the curve, but what's the quality of life like with chronic graft versus host disease, etc.? So now I'm going to play the expert card a bit. This is the Hippocratic Oath. Again, this is back to my first do no harm, and I think we need to think very carefully. This is actually for the original Hippocratic Oath, what we're doing here, and we want to make sure that we do not cause patients to suffer, hurt, or damage. The other thing I want to say is I wanted a picture of grey hair, but I thought Helen Mirren was quite a good example of that. If we all could look like that. But I've actually been a transplanter as well as an MPN doctor for many years, and I have seen what we are capable of doing to patients with transplant, and I'm not convinced it's always in the patient's best interest. It's great for the one who's lucky and is cured, but there are all these other problems. So I would contend for this 69-year-old lady, it's quality of life. We can't really tell what her survival is going to be. We haven't talked about the things we can give her. And in this case, I certainly would give her ruxolitinib. And can we give her as low a quality of life as possible rather than considering a procedure where she mightn't see 6 months? Thank you.
Thank you very much. So let's do the same as we did last time. Hands up. So now you've all got to put yourself in the position of a 69-year-old woman. Hands up if you'd like a transplant. Not many takers for that. 4, maybe possibly 5 in the room. Hands up if you're saying, no thanks to the transplant, I'll see how I do. Okay, so there's a fairly strong feeling against transplantation in the room. Okay, now, at this point, would anybody like to either ask a question or make a point from the floor? Great, okay. John, please.
John from Canada. The one thing I noticed was that the patient was transfusion dependent at this point, and I'm wondering if the graph that was put up about secondary MF survival took that into account. The person was at that stage.
I think it does to some extent, but the trouble is, it's the problem with all of this, that they're looking at these large retrospective data sets and trying to bring all the different bits in. But I would say to you that going into transplant transfusion dependent probably brings you down the graph for the possibility of survival from transplant, as well as probably being a factor is a decreased survival overall.
What I would add to this is, what is the perspective of this lady? She will have constitutional symptoms, she has a low quality of life, she's transfusion dependent, so her disease will end in a couple of years, for sure. The perspective I can offer with a transplant is that she is cured from her disease, she has a longer perspective, no longer transfusion dependent, which means she hadn't to go into the hospital every 2 weeks to get a transfusion. And of course there are risks to a transplant, but nowadays we are better able to control graft versus host disease, for example. And well, of course it's a choice you have to make as a patient. Do you accept that your ET has progressed into a post-ET MF and that your life is limited, or do you want to take the risk of a transplant? And that's something I discuss with my patients. Do you want to take the risk of the transplant with the risk of dying of your disease, which is at least 50%? That's what I tell my patients. And even then I see that patients sometimes say to me, I want a transplant. I want to take that risk because there is a chance of a better life.
Okay, so can I say that the last person I transplanted with myelofibrosis, who was 48, and it was a sibling, and it was a no-brainer, you transplant this person, is still needing 2 units of blood every week, 8 months later. So
Then you did
you're
something
selling the
wrong.
Yeah, but
Then
that
there
doesn't
is
matter what's
something
gone
wrong.
wrong. They've had the transplant. You're saying that if you have the transplant, you'll solve all these problems, and that's not necessarily the case.
Well, depends on how you transplant. But most of my patients, the patients, either they die or they, in my view, or they have a good quality of life. So that's, but certainly it's a risk you have to discuss with your patient. Yeah.
Sorry, Peter.
What do you want to say with it depends on the way how you make the transplant?
We are making progress in transplanting. We better control graft versus host disease, which certainly has a negative impact on quality of life after a transplant. And we have transplants now. What we do is we have tricks to reduce graft versus host disease by reducing T cells in the graft and or post-allo cyclophosphamide, so there are new developments. So that will limit graft versus host disease and get a better chance of cure of the disease.
Yes, of course we have better transplants than we had, but they still run into lots of problems. You still see people getting graft versus host disease. You see them getting infections. You see poor grafts, etc., etc.
Yeah, but you have to. Well, that's something a patient has to decide herself, himself. Do I go for a chance of cure, or do I accept that my quality of life is only going down and it will end soon?
Ilse, you wanted to make a point?
Yes, Ilse from Belgium. I knew a girl that was very young with an MPN, and she died at the age of 26 after 2 transplantations. I don't know what other things were going on, but it was, for me, really like, okay, it's really tough time she had.
I can show you at least the positive examples. Patients that would have been dead and who now have a good quality of life. Transplant is difficult, but it's the only way to cure the disease, because you give new stem cells to these patients. And I have patients that walk around in good health and they have quality of life. And that are the patients that I see on the ward. The other ones I don't see anymore.
You don't see them anymore.
Yeah.
Claire, you'd like to say something?
This patient is going to die of her disease unless she gets treated. That average life expectancy for a woman, in Europe at least, I think is 85. So, Mary Frances, I'm sorry, but you and I both presented treatments in the pipeline this morning, and I didn't see anything that was going to cure this patient apart from bone marrow transplantation. And of course, we have to primarily make the patient suffer no hurt or damage, but we should at least give them the choice. And some patients will clearly choose transplantation because, again, if you look at the pie charts that you put up, actually the predominant aim for the MF patient was to cure my disease, to stop progression. And that there is no other therapy that could do this. Sorry, I'm being provocative, by the way. And feel sorry for me because John's my patient. He's just like that in the waiting room.
And I would just have a question back to that. Stem cell transplant, the first 2 weeks of engraftment, the patient goes to hell and back in their symptoms, and diarrhea, nausea, fevers, transfusion dependency, probably within that first month, and the patient feels like they've gone to hell and maybe are coming back to some normalcy.
And back.
Just throwing that out there, are some patients willing to go through those symptoms?
You're quite right. I always say to my patients, a transplant is an investment, and you have to take 6 months, at least a year, before you really catch up and have quality of life. So the question to my patient is, do you want to make that investment, yes or no? With risks of dying in between.
Still not a guarantee.
Any other points from the floor? Yeah, please.
I have a question in regards to circumstances. We're looking at the medical pro and cons. But what if this 69-year-old still somehow has got a really good reason for living? Do you guys look at that as well? Like, I can't imagine she would have little dependents, but there's a lot more reason to live besides dependence.
I think that's actually to the quality of life. What are all the issues here? And of course, in practice, it's what the patient wants and all the issues that come in for that patient. But actually, you can turn that round the other way, that if they have if there are issues and dependence, they may be very much not wanting a transplant because they want to sort of get the way to almost guarantee to live as long as possible. So there's a whole lot of issues in an individual patient that will have to be considered. And ultimately, of course, it's what the patient wants. Of course it is.
Okay, so if your advice is that you probably shouldn't, if the patient says, well, I've got other reasons to live for, then you would accept that?
I think that's for further discussion, because it's still within the context of look at the overall survival graph, and that isn't a selected group of patients, that's actually patients who had transplants. It goes down fairly steeply. Is that what they want, that there's a 50% chance that they will not be there at all in a year?
Yeah.
You've got to look at it from both sides.
Thank you.
Yeah, so I think it's the most important thing. These are difficult discussions, and we have to be fair with our patients, show them the risks of dying of the transplant, show them the risks of a investment that takes half a year or a year. On the other hand, still, it depends on what do you want in life, and do you want to take that risk? But difficult discussion, yeah.
The other thing I think is a big issue for doctors, and this is sort of a bit where the grey hair comes in, but as things come in, there's an doctors that because they can do something, they should do it. As soon as something is suggested as a potential cure, it should be done for everybody. And I think you have to be, just because you can do something, just because we can, doesn't mean that we should do it to everyone who falls within that group. And I think you have to be very careful of that.
Giora.
Well, I think in CML this discussion was taking place 10 or 15 years ago. But from my experience, and I want to hear your opinion, when our patient go to doctor consulting this issue, so if the doctor has a transplant background, he will push for the transplant. And if the patient will go to a doctor which is a non-transplant, he will push for another option. So actually, the decision is not made by the correct or wrong answer. It depends what type of doctor it is, and how can the patient who is going to see one doctor who is in clinical practice and another one who is in transplant, how can he make up his mind?
Yeah, that's why you, as a patient, have to see more doctors. Ask for a second opinion, and On the other hand, what you told about CML, that's a different discussion. We transplanted for CML because CML will progress within a year to a blast crisis. So it was more or less preventive to transplant these patients. And that is different in MPNs.
Felice, you'd like to add something?
Just a comment. Yes, I agree with Reinier because it's totally different from CML. In this case, we have just expectancy the 2D because the people is 2 year he go to die, no? And in other case, you have the possibility to change your future. Then I think it's not depend from the physician if it's oriented or not oriented, because there are no cure. There are just to maintain your life for 2 years also. Then I think it's important to share this opportunity with the patient. I have a case in Italy with the patient who for many years was not treated or treated with hydroxyurea or other kind. And the mind is changed because you stay in the treatment for many years. And when you receive the information, this is the stop and to decide the way you decide right or left you go, transplantation or not. And this is certainly you die. In this other way, it's possible you live for many years also. Then it's important to talk with the patient.
Robbie.
Robbie from Israel. I just want to say almost the same like Felice. I believe that the statistic is probably very clear. And what the people need in general, it's the hope. And if you make transplantation, you have some hope in the future that maybe you can live in a good quality of life. Otherwise, you are going and just finishing a long agony. And if I had to take this decision, I would ask the doctor to provide me all the data that he can provide me. What are the statistic side? And so I had to gamble. And but it's a clear statistic that you can take, but it's not so easy. It's cruel that you are doing on your behalf. It's the only point that I see here.
Mary Frances, I've got a question for you. To Giora's point, do you think it's valid point that some doctors are transplant fans and some aren't?
Absolutely.
And in a given situation like this, you could be potentially swayed by that kind of enthusiasm of a doctor for transplantation?
Absolutely. Absolutely. And I've seen this because I used to work in CML and still do, where, transplant was the only option. It was easy if you were 40, it was the same thing. The other thing I would put in to be even more cynical about it, what is the doctor being paid to do? If you're a transplant doctor in certain countries, you have to do transplants.
Okay, so there's a can of worms right there. Ilse.
Say you survive the transplant, that doesn't mean your quality of life will be better. For a lot of patients, they have other issues, other burdens in that time that they have to live, and real severe burdens.
I agree on that. It's not a guarantee, but I can show patients that do well, a lot of them are doing really well, and they have better quality. I see some patients that already improve short after transplant because they get rid of their constitutional symptoms, they feel less tired. So that might happen, but it's no guarantee. That makes the discussion so complicated.
Excellent. Claire, you have a... Shall we make this the last point and then we'll do another show of hands? Go on then, Claire.
I just wanted to say I think patient advocates also have a role here. So we actually also have a patient advocate in the UK who contacts many patients around the time that they need transplantation and talks to them about it. But we have to be very careful in that situation because, of course, he's a patient that successfully went through transplant. And unfortunately, you can't have as an advocate a patient who did not successfully go through transplant. But I do sometimes put my patients in touch with patients who do have chronic graft versus host disease or the families of patients who've been through a transplant.
Fantastic. So let's have a closing show of hands on this one then. So put your hand up if you would like to have the transplant. Okay, so definite improvement on the transplant front. Put your hand up if you'd rather not and you'd rather see how things turn out for you. Okay, so much more balance on that one now. Okay, so an improvement from the point of view of the transplanter there. Very good. One last show of hands, if you don't mind, and that's about this format of kind of session. Put your hands up if you like the kind of debate and the to and fro. Put your hand up if you think it was a disaster and we should never try it again. Thank you very much. That was very good. And thank you very much to the participants.